Hi there, this is the continuation of our topic, mechanical ventilation a nurse must know. On this video, I'm going to simplify the settings and modes of the mechanical ventilation. I'll try to discuss this briefly and less technical as much as possible. Otherwise, what's the point of making a short video if the content narrative is same as the textbook, right? Okay, without further ado, let's move on to our topic. Mechanical ventilation can be non-invasive or invasive. Is termed invasive if involves any instrument inside your trachea through the mouth, such as the ET tube or the endotracheal tube, and through the skin, such as a tracheostomy tube. In non-invasive mechanical ventilation, we use face mask, nasal cannula, and a bag valve mask on appropriately selected conscious patient. Mechanical ventilation can be realized with one of the three operating principles: the intermittent positive pressure ventilation or the IPPV, intermittent negative pressure ventilation or the INPV, and the high frequency ventilation. Of this, intermittent positive pressure ventilation is currently the most popular and is the basis for most commercially available ventilators, whether invasive or non-invasive. Therefore, the focus of this video is on that principle. The two common ventilator designs that based on INPV are the iron lung and the Keras ventilators. Different variations of the iron lung were developed during 1920s and 1930s. They were used widely during the polio outbreaks in the 1940s and 1950s, if I'm not mistaken. The second type is the Keras ventilator, in which a rigid shell or Keras fits over the thoracic area only, and then an intermittent negative pressure is applied locally to change the thoracic volume. The third principle of mechanical ventilation is the high frequency ventilation or the HFV, which use higher respiratory rate, 150 or even higher. Clinically, HFV is often applied in neonates. Sometimes it's also used to treat patients with ARDS, especially those who requires very high positive airway pressure. HFV can be combined with conventional IPPV as well as surfactant therapy. Okay, let's talk about the modes of mechanical ventilation. But before we move on to that topic, you need to have an understanding, or you need to first develop an understanding of the mechanical ventilator settings. Actually, I've discussed this already on the previous video. Most of the settings, I think. Ventilator settings are tailored to the underlying condition, but the basic principles are the respiratory rate, tidal volume, fraction of inspired oxygen or the FiO2, positive and expiratory pressure or the PEEP, sensitivity or trigger, inspiratory-expiratory ratio. So the IE ratio refers to the ratio of inspiratory time and expiratory time. In normal spontaneous breathing, the expiratory time is about twice as long as the inspiratory time. Then the inspiratory flow rate, which determines how fast is the tidal volume can be delivered to the patient. And of course, the ventilator settings, ventilator alarms. From these settings, we need to be part in monitoring ventilator-based parameters such as capnography, minute ventilation, the pressures that I've discussed in the previous video, the peak pressure or the PIP, plateau pressure, mean pressure, driving pressure, and the resistance and compliance. I said be part of monitoring this because actually this area of expertise is belonging to the respiratory therapist. However, it's good to know as a bedside critical care nurse. Respiratory rate and tidal volume controls the carbon dioxide. These are the settings we're adjusting to achieve the desired partial carbon dioxide. On the other hand, FiO2 and the PEEP are for oxygenation. Okay, now let's talk about this controversial topic, modes of mechanical ventilator. Why controversial? Actually, it's a hot topic. New modes of mechanical ventilation is the subject for many talks at professional Congress of Intensive Care Medicine and Respiratory Care. It's almost impossible to know the exact number of ventilation modes that have ever existed. Old modes disappear and new ones emerge. Actually, the terminology of ventilation modes is not globally standardized, and the ventilator manufacturers and the researchers enjoy the freedom to name new modes of ventilation. Consequently, it creates confusion. Some modes with similar names behave very differently, while others modes with dissimilar names can behave similarly. Look at this comparison of contemporary mechanical ventilators and the name of their modes. See? Books, articles, and lectures discusses and classified modes of ventilators differently, but basically all common ventilator modes can be divided roughly into three categories: conventional, adaptive ventilation modes, and by basic ventilation modes. In these categories, it's either mandatory or spontaneous assisted modes. Conventional ventilation modes refers to the most developed and widely used ventilation modes. In conventional mode, the ventilator works exactly according to the operator's setting. That is, none of the ventilator settings is automatically regulated. This is the foundation of the modes in the other categories. Adaptive ventilation modes are basically conventional modes in which one or more control settings are automatically regulated. It's a kind of smart ventilator. By basic ventilation modes are a special form of continuous positive airway pressure, CPAP, where the baseline pressure alternates intermittently between two positive pressure levels according to the operator's settings. The ventilated patient can breathe spontaneously on either level. Okay, I'll explain first the mandatory ventilation mode, and the mode is the CMV, controlled mechanical ventilation or continuous mandatory ventilation. This is a mode where the patient is not allowed to breathe on his or her own. The breaths in this mode are all from ventilator, none from patient, or patient is not allowed. Operators set the parameters like the tidal volume, the RR, to generate desired minute ventilation. The patient cannot trigger a ventilation even they wanted to. So that is the CMV mode. Then let's move on to the next one. The AC or the assist control. Here, you also have a set parameter like tidal volume and a minute minimum rate. But the patient is allowed to initiate a breath through the triggering sensitivity. It can be flow triggered or pressure triggered. By the way, all ventilator modes may have same settings, but some settings not needed and some needed by the other modes. Okay, so where are we? Okay. The AC mode. As I've said, in AC mode, patient is allowed to initiate breath. Actually, most of the ventilator breath are time cycled or time triggered. For example, you set the RR to 10. The breath will be automatically time cycled because ventilator will give breath every 6 seconds. Why? Because 60 seconds divided by 12 is equal to 6 seconds. In an assist control mode, the patient is allowed to initiate a breath between these 6 seconds. For instance, the MEC vents gives a breath now. Then the ventilator will wait for another 6 seconds to give the next breath. But if the ventilator senses that the patient wants to breathe through trigger mechanism, then the machine will say, "Oh, you want to breathe, huh? Well, let's not wait for that remaining seconds. I'll give what you want." Then the ventilator will initiate a breath in a set flow rate and a set tidal volume. And after that, the vent will wait again for another 6 seconds to initiate a breath if the patient will not trigger a breath. Okay? Or if the patient will not provide a trigger. The only difference between CMV and AC is that in AC, the patient is allowed to initiate a breath or allowed to trigger a breath. And when they do that, the ventilator will deliver the set tidal volume in a set flow rate. Okay? It's clear, guys, or I don't make sense? Please leave a comment below if doesn't make sense what I'm saying here. Honestly, I'm not a professor or a clinical instructor. I'm just a regular nurse like you guys, but I do really love reading and learning critical care and have this urge to share and simplify the topic I've learned, and I want you to learn what I've learned. So it's my way of giving back because this profession gives me a lot, and thanks God continuously giving me more. So that's good. Okay, moving on. The next mode is SIMV, or the Synchronized Intermittent Mandatory Ventilation. From the name itself, you have the idea already what this mode does. The mode gives a mandatory breath intermittently and or in synchrony with the patient. SIMV mode is the hybrid variation of the intermittent mandatory ventilation, or IMV, which is, I think, obsolete already. Okay. For example, in this SIMV mode, you set the ventilator to give a set tidal volume and a flow rate every 10 seconds. So that is 6 mandatory breath per minute, right? Or 6 RR per minute. In between those 10 seconds, the patient is allowed to breathe spontaneously, not a trigger breath or not a ventilator breath, but a patient breath, his or her own breath. Let me give you an illustration. This is the breath that the mechanical ventilator giving mandatorily. In between this, the patient is allowed to have his or her own breath. This is where another ventilator setting is added. And this is the pressure support. Pressure support, or PS, helps in reducing airway resistance and keeping airways open and patent during spontaneous breathing. This will make easier for the patient to breathe and achieve a good tidal volume. And another reason why we're giving pressure support is that, we can't imagine how it feels to be intubated because most of us haven't experienced it yet, to breathe in that narrow tube, right? Adding up the whole length of the ventilator circuits, that will surely contribute to the work of breathing. Now, try to grab endotracheal tube size 0.5 or 8 in your area and seal it in your mouth and breathe on that. I'm pretty sure it's hard. Okay. On this illustration, maybe you wonder what will happen if the patient spontaneously breathe near or exactly on the time the ventilator is scheduled to deliver a breath. The ventilator will be synchronized with the patient. The machine can give it just a little bit earlier if the spontaneous breath falls near to the mandatory breath. That is why we called it synchronized intermittent mandatory ventilation. All right? Okay. So, when we say CMV mode, it's all ventilator breath, no patient effort. Patient is off limit, not allowed to have own breath even they wanted to. And in short, the ventilator does all the work. This can be achieved through volume control or pressure control. So this is the either VC or PC mandatory ventilation. The possible settings for volume-controlled ventilation mode is FiO2, RR, VT, IE ratio, flow rate, and PEEP. Therefore, this mode is volume-controlled, time-cycled, machine-triggered, and constant inspiratory rate. The patient receives the set tidal volume with every mandatory breath, and patient can do nothing. Okay? Patient can do nothing. The number of mandatory breath is defined by the frequency or the RR. This means that the minute volume remains constant over time. How about PC-CMV? During pressure-controlled ventilation, you have a set pressure and set inspired time, and the patient can't do anything in between. During pressure-controlled ventilation, two pressure levels are kept constant, the PEEP and pressure inspired. The possible settings in these modes are FiO2, pressure inspired or often called PC or pressure control, I time or the inspired time, RR, PEEP, and slope or rise time. Okay, now when we talk about AC, this can also be achieved through volume control or pressure control. It doesn't change how assist control works. In assist control volume control, the possible settings are FiO2, RR, VT, IE ratio, flow rate, PEEP, and additional patient-triggered type and sensitivity. That's the difference. Whereas PCAC has these settings: FiO2, pressure inspired or the PC, I time, RR, PEEP, rise time, and trigger sensitivity. All right? Okay. How about SIMV? SIMV, just like CMV and AC, we have VC-CMV and PC-CMV. The only special about SIMV from the two is that the patient can have a breath on its own in between the set ventilator breath. Either your SIMV mode is volume control or pressure control. Okay, that's how this works, guys. CMV mode can be VC or PC, and the machine do the job. AC mode can be VC or PC, but the patient can trigger the breath, and the machine gives the preset breath that operator set. Okay, and then the SIMV mode can also be volume or pressure control, and the patient can breathe on its own or between set ventilator breath or in synchrony if the patient triggers a breath near the mandatory breath. Okay, so that's it. Okay, let me ask you something. When you have a patient, for example, on SIMV mode with the RR of 12, tidal volume of 500, minimal FiO2, and hemodynamically stable, but on fentanyl and Nimbex infusion. So Nimbex is cisatracorium, a muscle relaxant. What mode of ventilation he's on? The mode is suitable for the patient? Come to think of it, Well, for me, patient is same as having a VC-CMV mode because he is sedated and paralyzed. He cannot have a trigger nor gives an spontaneous breathing. The breath he's taking is the mandatory preset breath of the SIMV mode. My point here is that all of these modes are the same if the patient has no breath, effort, or contribution on the process. They all have preset breath that is given in preset cycle. What I don't understand is that people try to break down this mode into 6 to 9 modes, which is in fact, these 3 modes are the same if the patient have no spontaneous or no trigger. They all give the same preset breath, right? Anyway, let's move on. The next mode I'm gonna talk about is the CPAP, continuous positive airway pressure ventilation. So what this mode does, this is a complete opposite of the SMV mode. Here, the patient does all the breathing. No ventilator breath, it's all patient effort. This mode is under assisted spontaneous ventilation. Right, we have 3 categories of the mechanical ventilation modes: the conventional ventilation modes, adaptive ventilation modes, and the basic ventilation modes. Those categories are either mandatory modes or spontaneous assisted modes. Okay, since this mode is a spontaneous mode, pressure support is needed. And by the way, almost all of the spontaneous mechanical ventilation modes are needed to have a pressure support. Okay. The possible settings are FiO2, PEEP, pressure support, and rise time. Okay. Now, let's briefly discuss the basic modes. In basic modes, the ventilator itself perform PEEP alternation according to the operator's settings, and the patient can have spontaneous breathing on the process. The modes have 4 unique controls to define how PEEP should alternate. These are the high level of PEEP or the PEEP high, the low level of PEEP or the PEEP low, T high or the duration of PEEP at the high level, and T low or the duration of the PEEP at the low level. In non-invasive ventilation, PEEP high and PEEP low are also called inspiratory positive airway pressure or the IPAP and expiratory positive pressure or the EPAP. Keep in mind that both pressures are PEEP. Currently, there are 2 basic ventilation modes: the BiPAP or the bi-level positive airway pressure, and APRV or the airway pressure release ventilation. Although this might have very different origins, both can be realized with the same technical arrangement but different settings. This is the reason why some of the ventilators have separate BiPAP and APRV modes, whereas others have a single mode for both BiPAP and APRV. We know that the 2 both perform PEEP alternation. So what's the difference? Okay, in BiPAP mode, all mechanical breaths are quasi-pressure control assist breath or pressure assist breath. The word quasi means that they mimic pressure control by PEEP alternation. So how is that? PEEP low serves as the PEEP, and the difference between PEEP high and PEEP low serves as the inspiratory pressure. The T high serves as the inspired time, and the T low serves as the expiratory time. So this is the IE ratio. The breaths are time or patient triggered, time cycled, and pressure controlled. However, in BiPAP, the patient can have breath spontaneously at either PEEP level, usually unsupported because PEEP high already provides ventilatory support. Some intensive care unit ventilators let you add extra pressure support to spontaneous breath. But the operators need to be careful because pressure support is specified differently in different ventilators. Make sure that you clearly understand how your ventilators in the unit works or defines pressure support before applying it. Okay. In theory, the BiPAP mode is beneficial for active patients only. It can be also used for passive patient, but no better. It's no better than conventional volume assist control or pressure assist control mode. Okay. Now, how about the APRV? So the airway pressure release ventilation. It can be regarded as a special form of BiPAP. But here, the settings have a relatively long T high and a very short T low period. PEEP high serves as the baseline pressure at which the patient breathes spontaneously. In short, if you reverse the IE ratio, then you have APRV. So airway pressure release ventilation has long inspiratory positive airway pressure, or the IPAP, and very short expiratory positive airway pressure, or EPAP. Okay? So that's the difference. Alright guys, that's it. That's the end of our topic, the summary of the mechanical ventilator modes. Alright, I hope you like it. Thanks.